Good afternoon, everyone. We will get started in a few minutes. All right, we want to give it another minute and we'll get promptly started at 12:02. Good afternoon. I am Jonathan Dinkins. I am your webinar facilitator for today's webinar. The Q&A box is where you will put your content-related questions. The chat box is disabled for all attendees. If you have any technical problems or difficulties, I can be reached at Q as in quiet, Z as in zebra, V as in Victor, the number 3 at cdc.gov. If we don't have any further questions or comments, I will pass it over to Katie.
Thank you. Hi, everyone. My name is Katie Riley. I'm a public health nurse with the HAI-AR team at the Massachusetts Department of Public Health. And welcome to Massachusetts facilities on behalf of myself and Melissa Cummings, who's the lead epidemiologist on the HAI team. I will pass it to Elizabeth in Maryland.
Thanks, Katie. Hi, everybody. My name is Elizabeth Vaith. I'm the AR Epidemiology Administrator for the Maryland Department of Health, and I want to welcome all of our Maryland acute care and long-term care people joining us today. We're really glad to have you, and I will pass it over to Candace.
Good afternoon, all. I'm Candace Johnson. I am the HAI-AR Program Manager for DC Health. I have been here for a short time, so I think I'm a newbie of the bunch for the HAI program coordinators or managers. And I want to welcome all of the DC facilities as well to the presentation. And I'll just pass the buck over to Shana.
Good afternoon, everyone. My name is Shana Bernard, the AR coordinator for the Virginia Department of Health. I'm here to welcome all of our Virginia colleagues. I will also be introducing our great speaker for today. So today we have Dr. Elizabeth Soda, who is an infectious diseases physician who started her career in public health as a hospital epidemiologist before joining the CDC. Since joining the CDC, she worked with the Illinois Department of Public Health to help with their response to multi-drug resistant organisms before moving to the antimicrobial resistance team with CDC's Division of Healthcare Quality Promotion in Atlanta. I will now turn it over to Dr. Soda.
Thank you so much, Shana, and I want to thank everyone for being here. I also want to give a quick shout out to Janet, my colleague Janet, who gave the hand hygiene webinar last month, and she's also going to be on hand to help answer any questions. So let's go ahead and get started. I'm also going to go ahead and come off camera just to make sure that I don't lose my bandwidth. All right. So just to start off, I don't have any disclosures, and I won't be talking about any unlabeled use of products or products under investigation. Here are today's objectives. And before we get started, I just want to give a little background on today's talk, and it's really going to be meant to be a pretty basic overview of cleaning and disinfection principles within the healthcare setting. And it's primarily going to be intended for maybe our more novice colleagues, whether you're an infection preventionist or an environmental service supervisor. So if you are a seasoned veteran, feel free to log off or go ahead and take a nap, or stay on. And if you have thoughts, comments, ability to answer questions, we also really value your expertise. Because it's such a short talk, it can't cover all the intricacies of environmental cleaning in this very short period of time. So I will reference you to some more in-depth trainings, though, if you want to check those out eventually. So for those of you who have joined us in our past talks, we've held several webinars now that are really focused on how do you reduce the spread of multi-drug resistant organisms. And just as a reminder, multi-drug resistant organism, or an MDRO, is a germ, usually a bacteria or fungi, that for whom drug treatments just don't work as well against, which makes them harder to treat if you end up with an infection against one of them. The term MDRO is actually an umbrella term. And so it covers, many different types of germs, some that you may be very familiar with already, like MRSA or VRE, C. diff. And there may be some MDROs that you are becoming more familiar with, right? Like Candida auris, or some of our carbapenem-resistant bacteria, like carbapenem-resistant enterobacterales, or CRE, CRAB, which is carbapenem-resistant Acinetobacter baumannii, or CRPA, which is carbapenem-resistant Pseudomonas aeruginosa. One really important thing to remember about MDROs is that they can either cause infection or colonization. So an infection is when someone gets that germ and that germ makes them sick. And those infected people can go ahead and pass those germs on to other people. But you can also be colonized with these bugs, which means that that germ can live on or inside of you, but it's not making you sick. But colonized people can develop an infection, and importantly, they can still spread that germ to other people despite being asymptomatic. And so in the past, we've really discussed these really 3 important steps of how we battle the MDROs. And today's talk is really going to focus on that second step, making sure that you have good baseline infection control practices. And today we'll really be focusing in on those cleaning and disinfection principles. So I'm going to start off with some very basic concepts. So as I mentioned, MDROs can move from infected or colonized people into their environment. So let's say we have a patient or a resident who has, let's say, Candida auris, which is represented by these red dots. Well, that Candida auris can spread to the environment. So, onto beds or other high-touch surfaces, right, like lights or bed top tables, and onto things like shared equipment. And then we will have healthcare personnel who may come into the environment. They can get that Candida auris on their hands or on their clothes. And if the environment isn't well cleaned, or they're not performing hand hygiene or wearing gowns and gloves, right, they can go on to pass that Candida auris on to other patients. And likewise, right, that shared patient equipment that may not have been cleaned and disinfected can go into another patient's room and then inadvertently spread it to other patients. And so really, one of the most important ways to break this chain of MDR spread is to really ensure good environmental cleaning and disinfection. All right, I'm going to give a poll a chance, and let's see if this works. So I'm going to launch a poll, and I'm hoping, let's see. Don't know. Okay.
Okay, Elizabeth, you're doing well.
Can you guys see it though?
Yes.
Hold on. Let me try again. Yeah.
I can see.
You can see. Are people able to select answers?
Elizabeth, I'm not able to select answers, but maybe that's on my end.
I am also not seeing that it's
Neither
logged.
am I.
Oh, bummer. Jonathan, do you want to try?
Sure. You come out of the poll.
I'm out.
All right.
But while you're doing that, the poll question's about Acinetobacter baumannii, which is a germ. Great, it looks like people are able to get in, yay. And it can heavily contaminate surfaces and cause outbreaks. So wondering what people think about how long it could live on surfaces if not clean and disinfected. Options are 5 minutes, 1 hour, 1 day, 5 months, or I just don't know, which is okay. And Jonathan, I think we can just go ahead and end that poll and share the results. And it looks like most folks think 5 months. And indeed, you are correct. So germs can live on healthcare surfaces for any amount of time. And some of it can be from hours to months, depending upon that germ. Acinetobacter baumannii is a really problematic bug because it can contaminate surfaces for a long time, up to 5 months, if you're not cleaning and disinfecting well. And as you can imagine, that then leaves plenty of opportunity for that bug to spread to other people, and those other people may move to other facilities, and you can see how it sort of snowballs. And if you look at my table, you can also see that there are other bugs that can last for even longer than that. So again, really reiterating the point that, right, if we don't do something about them, they're just not going to go away on their own. All right. So, at its core, what's the difference between cleaning and disinfecting? So I think we sometimes use them as interchangeable terms. But cleaning really means the process of removing the dirt so that the disinfectant is able to get to the germs that you can't see. So this usually involves adding detergents or some type of enzymatic product to water, and then using that solution to wipe the surface to lift the dirt and germs away from the surfaces. Cleaning may reduce the number of germs left behind, but it doesn't always kill them, which is why disinfecting is so important, because disinfecting does kill most germs on surfaces and objects when you use a chemical called a disinfectant. And it really is one of the most reliable ways of lowering the risk of spread from contaminated surfaces. So again, it's really important that you always clean first to remove, the dirt and other materials that may make your disinfectant less effective. Or you can use a product that both cleans and disinfects, and we'll talk more about that soon. I think as many of you probably are aware, different germs require different levels of disinfection. This table, I think, is a nice table to go back and refer to, right? We have things like chemical sterilants, which, we'll get at all types of bugs. But, more classically within our everyday cleaning, we typically tend to use more like intermediate level, or abbreviated as ILD, or lower level disinfectants. But you can see how the differences that exist between them, right? So an intermediate level disinfectant will, get many of the different types of bugs we want to target, but we'll miss some things, right? Like some bacterial spores, maybe some non-enveloped viruses, and lower level disinfectants will miss even more. So this could just be a helpful table to go back and think about. Also just listed here some of the very common low and intermediate level disinfectants, and I'm sure many of you already use at your facility. Due to time, I'm not going to speak in depth about them, but really want to point out that there's this really great link available here through CDC that talks about some of the advantages and disadvantages of each if you ever want to learn more. So for the remainder of the talk, I really want to focus on the core components of environmental cleaning and disinfection, which is a tool that the CDC recently released. And here are the 6 different core components. And the first core component is to really make sure that you're integrating environmental services into your facility safety culture. And when I talk about safety culture, that's really a facility's values, attitudes, perceptions, competencies, and patterns of behavior that determine their commitment to health and safety management. As we all know, EVS personnel are those who are primarily responsible for cleaning and disinfecting the healthcare environment. And they really are essential members of the team who should have defined management structure and clear reporting and accountabilities. And we really encourage facilities to make sure that they develop performance evaluation and career advancement structure and have supervisors who encourage excellence, reward expertise and skill, and optimize retention. In addition, if not in place already, we encourage facilities to think about establishing a multidisciplinary cleaning and disinfection program, which isn't only just EVS, but should include other disciplines like facility leadership, quality, nursing, purchasing, facility management, and infection control. Because really together, it's this group of great individuals who can help implement and evaluate the effectiveness of an EVS program. The second core component is to ensure education and training of all healthcare personnel with any type of cleaning or disinfecting responsibilities. So we all know that many healthcare personnel beyond EVS staff will have some cleaning and disinfecting duties. And so when I talk about education and training, that really means anybody with those duties should be educated, trained, and able to demonstrate competency based upon their responsibilities. And of course, those trainings really need to be tailored to education levels, language, and learning styles. We recommend that this kind of education is occurring at hire and then at least annually thereafter, but really thinking about the fact that you may need additional education sessions, right? So if you're introducing new equipment or protocols, folks will need to be educated on how to use those things. Certainly, if you're in the middle of an outbreak of any sort, or you think that you may be at risk of an outbreak, re-educating folks on those principles are always helpful. And then, as part of your auditing activities, which we'll discuss a little bit later, you may identify staff members who may need some extra training again to help get across some of the policies and principles that you want to ensure they know. Another really important thing is to make sure you're keeping documentation of all your training so that, for instance, when your friendly public health official comes in and asks about your training, you can proudly show that indeed, you have been training and these are the folks who have completed them. What kind of topics would we suggest training folks on in this under environmental cleaning and disinfection? So one, making sure that everyone understands how germs spread in the healthcare setting. I think the more people understand how this happens, the better able they are to help prevent it. Of course, emphasizing the importance of cleaning and disinfection and its role in infection control and patient safety. And then, of course, really making sure that people understand your policies and your standard operating procedures. And that would, of course, include making sure that they know how to use and can demonstrate how to use the products and materials they have for these activities. Also important to make sure folks understand how maybe policies and procedures change for certain germs, right? So for patients who have Candida auris, cleaning procedures may need to change, right? They may need to use different products and maybe use like different types of personal protective equipment. And it's also important to make sure that staff understand some of the infection control risks, right? Like how do they handle sharps safely, and making sure they understand, when and how to select personal protective equipment. So the third component I want to spend a little bit more time on is making sure that you're selecting the right cleaning and disinfecting products for your needs. And there are all types of things that need to go into this when you think about your products. And some of those include, what kind of germs do I need to target? What is the contact time? How effective or efficient my product is? Safety and health concerns. How do I prepare my product and how do I store it? What happens if I need to use it multiple times on certain types of surfaces? Is it going to destroy my surface, right? Like, does it have a funny smell? And maybe my healthcare personnel patients don't want to use that product. And then, of course, is there any type of specialized expertise or training? We are going to dive a little deeper into all of those considerations, but first, let's see if we can get another poll to run. And this is out of curiosity. How many of your facilities are actually using a disinfectant product currently with activity against Candida auris? Jonathan, do you think you can try to launch that poll for me?
Absolutely. Let's see. So this is poll number 2, and I am going to share and everyone select an answer.
Great, great. I think, Jonathan, we're about 50%. Maybe we can end the poll and share results. And it looks like about 56% are using disinfectant products against Candida auris, and about 30% aren't sure. So I think it's great. We can actually talk a little bit more about all of those concepts today. I'm going to stop sharing. All right. So one thing I just want to say about Candida auris in particular is that, highly recommending that if Candida auris has become an issue in sort of the area that your facility is located in, to really strongly consider bringing on disinfectants that can indeed kill it. Because, going back to the idea that, there could be folks in your facility who are colonized and may not be infected, and you may not know, and they may not know, but that Candida auris sure can get into the environment. And so, strongly considering that if you think Candida auris is, increasing or is a problem in your area. So how do you know if your product targets Candida auris or any other germs for that matter, right? So, always making sure, of course, that you're using an EPA registered hospital grade disinfectant. And there are a variety of ways of figuring out what it targets. But, looking at the product label is one easy way to do it. So you can see in my picture, it's not a great picture, but you can see right on this label, it talks directly about multi-drug resistant bacteria and the things that it kills. So you can see our front Acinetobacters on there. And you also can see on the label that under pathogenic fungi, it says Candida albicans. But you're like, gosh, I really thought somebody told me that this also covers Candida auris. Is there any way for me to confirm that? So yes, indeed there is. And many of you are probably aware of the Environmental Protection Agency lists. They have these lists, specifically A through P, that provide the registered products that are effective against common germs. And I've included the link to their list here. Due to SARS-CoV-2, you probably have heard about List N, which again are disinfectants with activity against SARS-CoV-2. Maybe you may not be as familiar, though, that List P is actually a pretty new list, and it's been created specifically for agents that are effective against Candida auris. So that would be one way that you could figure out if your product or the product you're interested in has activity against the auris. So how do you look up a product on the EPA list? Like, I had no idea, honestly, how to do this initially. So if you go to, for instance, like a bottle, they will have an EPA registration number on it. It's this number that you can see here. It's like 2 pairs of numbers on it. The other thing that I've always found sometimes confusing is that the entry on the EPA list may not have like the same commercial name, and like why is that? So some products will actually have like the same formulation, but will be given to like a different distributor or marketer with a different name or label. So, that basically means, right, what's inside the bottle is the same, but what's outside the bottle, it may be different. And if that's the case, you are going to see an EPA registration number with actually 3 pairs of numbers. My little box is highlighting the third set of numbers. And those are the supplemental numbers. But the numbers that you really need are just these first two, the numbers before and after the hyphen that I've got highlighted there, to look it up to make sure that your product is indeed on the EPA list. So my next poll question, which of the following is false about disinfectant contact time? So Jonathan, if you could try to launch it. Is it A, is the amount of time surfaces need to stay wet for adequate disinfection? B, you can just use the shortest contact time listed on the front of the bottle. C, if the surface dries before contact time, you must reapply the disinfectant. Or D, it can also be called a wet time or a kill time. And again, this is, what answer is false? Excellent. I think, Jonathan, we can go ahead and stop and share. And yeah, I think lots of folks are saying B, that you can just use the shortest contact time. And that is indeed the answer. All right. So yeah, contact time is the amount of time that your surface needs to stay wet for adequate disinfection, right? So that means if your surface dries, you must reapply your product. And this is such an important concept because if you have a product that has a 10-minute contact time, you can imagine, right? And I'm sure folks can attest that it can be very difficult to achieve that contact time without multiple reapplications. And as the audience seems to be well aware, it's always important to read the fine print. You know, sometimes like a bottle may kind of boldly advertise like a very short contact time, but when you read the fine print, you may realize that may be only true for some germs. So for instance, for many germs in this product that I'm showing, it's a short 1-minute contact time, but if we're actually interested in using it for Candida auris, that extends out to 10 minutes. Which of course can be clearly a pretty big difference. I think another really important thing about product selection is what I've alluded to before, and is that whether it's a 1-step or 2-step cleaning and disinfection product or process rather. So, if it's a 1-step process, that means you're using a product that can both clean and disinfect. And if you're wondering if your product can do that, oftentimes it should be on the label, right? So as an example I gave here, it says, it is a 1-step cleaner disinfectant. Just, as a note, sometimes even these may require a pre-clean though, even if the area is heavily soiled. If you're using a 2-step process, that means that you need to have both a cleaning and disinfectant product on hand so that you can clean first and then disinfect. And an example of this, a common example of this is liquid bleach, which requires a 2-step process. I just want to take a quick second to call out a little bit more about liquid bleach because it is used commonly, and I have found that sometimes facilities may struggle a little with it. So, one tip is, of course, that you should really only be using EPA-registered hospital-grade bleach products, so not those intended for household use. As I've mentioned, it is 2 steps, so you need to clean before using bleach. The other thing is, it has to be diluted correctly and per the manufacturer's instructions. And while you're doing that, making sure that you're wearing the required PPE while diluting, and of course, not mixing it with other products and discarding it after 24 hours. I do find that dilution can be a little tricky and if not even potentially a little dangerous. And so, having maybe just one or a couple people who know how to do this, like a supervisor or a designated staff member to go ahead and dilute for everybody is really maybe a good way to think about this. Of course, making sure you're adhering to the listed contact times. And I think many people can attest, right, that liquid bleach can't be used on all surfaces and can certainly destroy certain things. So you got to be really careful with it. Of course, other considerations is how easy the product is to use. the manufacturers often have great instructions on teaching you how to use their product correctly. I'm sure some of you have seen instructions like this. Like, I love how the pictures are there and they're well described in both English and Spanish. So that can really give you a sense of how easy it is to use. And then, checking out the safety data sheet, which tells you all about the safety of their product and how to use it. And just as a reminder, all employers must obtain the SDS and make sure that it's readily accessible to staff. So I guess in summary, right, there are many products out there that are effective, and there's not going to be really one best fit. And it's just really important for you to think about your needs, like what kind of germs you need to target, what kind of materials. Are you going to be using them for daily or terminal cleans? Are they going to be used on equipment or other environmental surfaces? And then sort of selecting them from there. And before we move on, I really want to highlight this idea of the no-touch products for disinfection, like hydrogen peroxide vapor, fogs, or UVC disinfection. I want to say that these are potential tools in the disinfection toolkit, but the evidence is still really mixed about whether they impact patient safety measures or if they're really improvements over current practice. Many of these treatments are still considered investigational. So as such, currently CDC does not recommend approved no-touch technologies over traditional cleaning and disinfection methods that we're talking about today. So the next core component is really making sure that you have standardized procedures and protocols. And part of having these well-developed procedures and protocols are making sure that some, I think, sort of the core topics are covered within your policies, procedures, and protocols. And just as a suggestion, here are some of the things that I think could be helpful to go into those, into some of these policies and procedures. And we'll talk a little bit more about each of these. I know, as you're all well aware, high-touch surfaces and high-touch equipment are really, really important when it comes to cleaning and disinfection so that we can prevent the spread of germs. Just a quick note on them, right, that your high-touch surfaces or equipment may be very different based upon the types of rooms, the ward, the facility type. So it's really important to identify and account for a variety of high-touch surfaces throughout a facility, and to make sure that you're setting your expectation regarding cleaning and disinfection of all these surfaces within your facility policies, procedures, and protocols. Here's an example of some high-touch surfaces I'm sure many of you are aware. And of course, this is not meant to be a totally exhaustive list. So next poll question, wondering how many facilities currently share what I call a who cleans wet list with their healthcare personnel. Jonathan, you can launch that. Excellent. I think we can go ahead and end it. And it does look like a majority of folks do, and it's okay if you don't, and you don't know what that is. We're going to talk about that next. So, as I've mentioned, it's really important for policies and protocols to really list out what your expectations are on high-touch surfaces, and that should include things like who's actually cleaning them. And, some of that is probably pretty obvious to folks, but I find, for example, like IV poles have been a challenge, right? So on a daily basis, who's responsible for cleaning that in a room? Is it the EVS staff, or is it nursing staff? And sometimes I find that folks may not know. And if they don't know, that means that it's probably possible that the IV pole itself isn't being cleaned at all. And so the purpose of a who cleans what list is to list out all of these different high-touch surfaces, and then assign them to different healthcare personnel types. And you can also include the frequency of that cleaning on the list, and then making sure that you share this with all healthcare personnel cleaning duty, whether they're new or they're veteran employees. And of course, anytime that there is an update in it, making sure everyone gets that. So, here's an example of a Who's Clean wet list that I helped an urgent care clinic make. So this is a little bit different setting than probably many of you are in, but, for instance, they had both EVS and nursing help take care of cleaning and disinfecting. And, for instance, they listed out all of the high-touch surfaces within their patient rooms. EVS was responsible for cleaning the mattresses both in the morning and the evening, and then nursing was responsible for doing it after every patient. So, sort of modeling something like this can be really helpful. Again, going back to the frequency, important to include that within your policies and procedures. And you may wonder, well, how do I know how frequent things should be cleaned? And a large amount of that is really based upon the risk of germ transmission, right? So thinking about things like how probable are the surfaces or equipment to become contaminated, right? So is this a birthing suite or is this just a general patient room? And then also thinking about things like the underlying susceptibility of your patient or resident population, right? If you have a bone marrow transplant unit, that's a little bit different than a general medicine ward, or if you're a nursing home and you've got a vent unit, again, that's a little bit different than a normal floor. And so the higher the risk of germ transmission, the more frequently you need to clean and disinfect. So again, going back to the birthing suite, making sure you're cleaning that after each use and more is needed, whereas, probably once a day is going to be okay in those intermediate risk areas, but of course more as needed. And then like low risk areas like administrative offices, could be cleaned on a fixed schedule. I think also including some general expectations about best practices and cleaning and disinfecting techniques would be helpful. And so I'm just going to give a brief review on some of those topics. So, one, of course, just good general principle about cleaning and disinfection is making sure that staff always look at the area that needs cleaning before they enter. And that's to make sure, right, that the patient's status is safe and it allows for a safe cleaning process. Are there obstacles or clutter that need to be dealt with before you start the process? Are there damaged furniture or surfaces that need to be reported? And also thinking, is this person, for instance, on contact precautions? Do I need to wear additional PPE? And do I maybe need to change disinfectants, for instance, because let's say this person has Candida auris? I'm sure many of you have heard these mantras before, but I'm just going to go ahead and repeat them quickly. We generally recommend that you move from clean to dirty, so that the idea is that you're not spreading germs, right? And so we consider that the patient zone or the surfaces or items that are touched by the patient are going to be the ones that are potentially housing the greatest number of germs. And so we recommend starting cleaning outside of that patient zone and then moving into the patient zone. So again, moving cleanest to dirtiest, and always cleaning the bathrooms last. You may also want to think about these principles when you're on a floor where there are, some folks in transmission-based precautions and some are not. You may want to consider cleaning rooms under transmission-based precautions like contact precautions last. Other good techniques for thinking about moving from high to low, right? So that idea is that we're not letting germs drip or fall onto already cleaned areas, right? So that means cleaning bed rails before bed legs, cleaning surfaces before the floor, and then of course cleaning the floor last to remove any germs that may have fallen. We also recommend that you move around the room in the same way every time. So for instance, maybe moving around clockwise. And that's to just make sure that you're not missing any areas. Of course, making sure you're wiping surfaces with adequate amount of pressure and friction. And of course, always a call out to making sure that contact time is being adhered to. Couple thoughts on floors. So we do not recommend using brooms, but instead really encourage the use of mops or floor cloths instead. Recommend mopping in a figure 8 pattern with overlapping strokes. And again, same principles, moving from clean to dirty. So for instance, starting farthest from the exit and then moving towards it. It is really important to make sure you're changing your mop and floor cloth and product solutions often, particularly right immediately after rooms that are on transmission-based precautions, or if things are becoming visibly soiled, it's time to change those things. If you're not using pre-prepared wipes like that come out of a bottle, you really need to think about what kind of cleaning cloth materials you are using. We do really like microfiber cloths over cotton cloths, as they can do a better job of absorbing more germs and dirt. But a couple of things about them is it's important to remember they can be damaged by high pH disinfectants like chlorine-based disinfectants, and that they should be washed separately from cotton cloths because of the lint issue. Clean cloths, of course, should be saturated in cleaning and disinfecting solutions. And you can sort of handle them in multiple ways. You could fold and then rotate and unfold to use all sides. Or you can just, sort of get a new cloth once all sides are used and are no longer saturated. But I think the most important part is to never put a used cloth back into clean solution, and make sure that you're always storing clean cloths away from dirty ones. This is the 8-sided fold method that I just previously mentioned that could potentially help you maximize the use of your cloth. It may be a little bit tricky, but you can certainly take a look at this slide and figure out if it works for you. But again, just remember, don't ever re-dip that into the clean solution. Quick comment on shared patient equipment. So, I'm talking about things like lifts or wheelchairs, vital sign machines. We have actually cultured off a lot of our bag bugs from these, so Candida auris directly off that list. And because they move from patient to patient, they play potentially a really important role in some outbreaks of these bugs. And the other, of course, important thing to remember is that oftentimes the cleaning of these equipment are being conducted by non-EVS healthcare personnel, so maybe like a nurse or nurse's aide. So it's really important that those folks also understand, right, the who, what, when, where, and how of this process, and to make sure that once equipment is clean, that it's labeled and stored away from dirty equipment. Another really important consideration are for multi-patient or multi-resident rooms. I know particularly in the long-term care setting, this may be a particularly big challenge. But when you have multiple people in a room, really each patient bed space needs to be treated separately. So what does that mean? That means making sure that you're performing hand hygiene and changing your PPE between each bed space. So acting as if it is like a separate room. That also means making sure that, wipes or cloths are being changed between each bed space, but you still apply the same general cleaning techniques that we've talked about. And then this is our last poll question of the day. Wondering how many facilities use cleaning checklists and for what? So Jonathan, you want to launch that. Do you use cleaning checklists for sort of your routine cleans, for your terminal cleans? Do you have checklists for special areas like operating rooms? Or maybe you don't have checklists at all, or maybe you just don't know. Jonathan, do you think you can launch that for me?
Yes, ma'am.
Thank you.
You're welcome.
And you can select as many as you would like.
Is anybody selecting anything? I only see one, but is that on my part?
Yeah, I'm only seeing one person so far too.
So I'm gonna stop sharing, and what I'll do is I'll relaunch it, and everyone try to select, and let me see if it's working. There we go.
Yeah, that's great. I think, Jonathan, you can go ahead and stop.
Okay.
And it does look like the majority of participants are using checklists for routine cleaning and terminal cleaning. And then for folks where it's maybe most relevant, using them for like specialized settings like operating rooms, which is fantastic. So it sounds like many of you are already using them, which is great. And if you're not using them, I really encourage you to think about creating checklists to help ensure all healthcare personnel are performing cleaning and disinfection in the same manner. And as per your facilities policies and procedures, right? This just helps reduce the risk of missing steps. It can also eventually aid in auditing, which we'll get to in a second. But really, recommending, as many of you already are, having checklists for, routine cleaning, terminal cleaning. And if you have specialized areas like ORs, having them for those settings as well is really great. And this is just an example that, we do have an example of a terminal clean checklist that's available at that link if you ever want to take a look at one as an example. So our last core component, I'm going to talk about both of them together, and that's both monitoring adherence of healthcare personnel cleaning and disinfection to your policies and procedures, as well as providing feedback to staff on their performance. When I talk about auditing, it's really the process of monitoring, documenting, and then sharing your findings with the healthcare personnel who are expected to be sort of following your facilities, policies, and procedures when it comes to cleaning and disinfection. And it's really a very important step so that a facility can really understand how adequate is the process happening. I think one really important thing I want to highlight is that it's not just enough to just audit, but it really has to be that you're looking at your results, you're tabulating them, and then you're sharing that with staff so that everyone can understand, where we're at currently and if there are things that we need to do to change. One thing I really want to emphasize that we really encourage that this auditing is meant to be non-punitive and leads to non-punitive corrective action. So for instance, if a healthcare an EVS personnel is sort of consistently missing one component of the cleaning process, and you're retraining the person on that. There are multiple different ways of auditing environmental cleaning and disinfection. Direct observation is one of those methods. So that's either while you're watching someone conduct the cleaning process, or if you're inspecting a room after cleaning has already occurred. The problem though with that is that visual assessment alone is not really going to correlate with a reduction in microbial contamination, and so thus the room may look really clean, but that may not be like a true measure of cleanliness, right? So there are some alternative ways of looking at this. So one way is with a fluorescent marker, such as a gel or a lotion that can be applied to a surface. And then after the cleaning and disinfection process has happened, you can go back and assess using a black light to see if that material has been removed. So here's an example, right? Actually a very aggressive example of a marking with lots of fluorescent material. So that's pre-clean, post-clean, you would come back and you flash that black light and you would visibly see if the majority of that fluorescent marker has been removed. This method has been regionally shown to correlate to the removal of microbial contamination, but it is important to remember that you don't want to mark the same surfaces all the time. You don't want to do it on the same day because then staff may just be sort of performing to the test and you may not be getting the most accurate of assessments. Other auditing options, you may have heard about Atp Bioluminescence. So an ATP meter is like a handheld tool that can measure organic adenosine triphosphate, or ATP, that's due to both germs and non-germs on surfaces. It has been shown to improve daily cleaning while providing a quantitative measure of cleanliness. They are probably a more expensive option than going with a fluorescent marker, but again, is a really nice way of conducting audits. The CDC website that I've got listed here below has a lot of nice discussions about auditing and different ways of doing it. So I'd really encourage you that if you don't have an auditing program, to take a look at this, ask your public health department about ways to think about including auditing in your program, because it is so important. And for those of you who have attended my past talks, I may sound like a broken record, but I really, again, want to emphasize how important communication is when transferring those with MDROs. And to think with a little bit of a spin from an environmental cleaning perspective is that, if you can also try to share when the person transfers that maybe they may need like a special cleaning or disinfection product. So for instance, if you're transferring a patient with Candida auris, if it can be communicated to the receiving facility that they do need to make sure they're using specific products, that can really help spread that knowledge and ensure that we're all using the right products for that. And then again, really encouraging all facilities to think about how to best do this with their other facilities in their networks, whether that's forms or calls or through electronic health record reminders. I know it can be a really big challenge, and hopefully at the end of September, early October, we're going to have a webinar just dedicated to communication. So look forward to talking more about this with y'all. So, I hope if nothing else today, I was able to show you that environmental cleaning and disinfection is such a critical part of patient, resident, and healthcare personnel health and safety. And so really asking facilities to dedicate sufficient resources to education, training, and auditing for this process. And that, how important it really is to make sure that there are clear policies, protocols, procedures, and checklists within their programs to make sure that they're developing an effective program. I also encourage you to put on your thinking caps and think about maybe how your facility currently is or is not integrating these core components. Which ones are you already doing really well, and which maybe present some opportunities for improvement. As promised, I mentioned that there are many professional organizations that provide trainings, and here are some training links. Again, this will all be in the slides. And I've also included some additional resources for you. Here are the list of contacts for the jurisdictions that help sponsor this webinar. If you are not from one of these jurisdictions but have questions, you can reach out to me through that Zoom email that you received with your webinar link. And just as a reminder, this talk is eligible for CE. If you received a registration flyer or information that way, and that's how you registered, CE information is on that. Other ways to figure out how to get CE, you can email me again through that Zoom link, or you can take a look at this website. This is where the recording and slides will be posted. So you can either maybe take a screenshot if able, or if not, I just Google Virginia MDRO webinar series, and that brings you right, it's like your top hit, and will bring you to that website where again, you can find the recording, these slides, and some of our old webinars for you to look back on. I also want to note that if you've missed our earlier webinars and you want to listen to them, you can actually get CE for those recordings as well. So I think that's going to wrap us up today. I really, really want to thank you all for attending. We can take questions. And just a plug, I think next month's webinar will be at the end of the month in July, and it's going to be focused on carbapenem-resistant organisms. So, all those alphabet terms that are super confusing, please attend and ask any questions that you have about them. So yeah, I think we can open them up for questions, and thank you.
Elizabeth, one of the great questions that was put in the chat was, or in the Q&A box, are there any current preventative recommendations for environmental services rather than waiting until a patient tests positive for one of these organisms? Do we need to rethink our standard approach to cleaning and disinfection to be more proactive? So what do you think of choosing an organism in anticipation that C. auris may come to your area?
Yeah, and that's a great question and a great point. Thank you for making that point. I think that's exactly right. And I think exactly the point about thinking about the germs that are in your area and proactively choosing products that are going to be effective against it. So I again, sort of going back to my crystal ball slide, if you are aware of Candida auris in the area, and for many of you, that probably is the case, really thinking about switching over to that disinfectant product now.
And a related question was, while the low-level disinfectant for shared medical equipment is active against C. auris, the EVS discharge cleaning chemical is not. Do you recommend changing to routinely using a chemical with activity against C. auris? It's kind of related to the last question, a little different.
Yeah, so I guess the question is, if like for shared equipment, is that right, Janet?
Yeah, it's like some of the products, like for shared equipment, like I would think the nursing product is maybe used by or has effectiveness against C. auris, but the EVS product does not. So
yeah,
different.
Or vice versa. Yeah, exactly. Yeah. So yeah, all of your products should have that that kill claim for Candida auris, because Candida auris and bugs like Acinetobacter baumannii, they are really big environmental contaminants. When we go culturing for them, we will find them everywhere. We have cultured them off of window cells. We've cultured them off of vital sign machines, glucometers. It gets there, it sticks, and it just, you've got to use the right product to get rid of them. So absolutely, I think, using a product to clean all your surfaces, super important that have that kill claim. Absolutely.
And I would just put a little boundaries about that, and that's if C. auris has been identified in any healthcare facility in your area.
Exactly.
So if you know it's in a long-term care facility, then your hospital should be responding, proactively.
Yeah, exactly.
I would also want to point out, and you can kind of build on this, Elizabeth, and I know we just have a minute, but for those gram-negative MDROs, the list goes on and on, right? And there's probably not an EBS list, for Acinetobacter baumannii, for example. So in that case, we would recommend, if you're looking at something with a tuberculocidal claim, anything with a tuberculocidal claim is going to be an intermediate level disinfectant. And we don't recommend anything specifically for Acinetobacter baumannii, but you do need to, make sure that you've got something that is effective against those gram negatives. And most of your low-level disinfectants are going to be effective. Your healthcare, disinfectants, and then those ones with the tuberculocidal claim. So if you want something that's effective against organisms that are a little bit hardier, look for that tuberculocidal claim.
Yeah, good point. Thank you, Janet, for highlighting that for sure. I see a question on UV treatments of rooms, and I'm curious to get your take on this as well, Janet. I sort of think that that sort of currently falling in the sort of no touch still needs to be further evaluated. Not necessarily recommending it as an alternative to our sort of current cleaning and disinfection standards, but wondering if you have additional thoughts on UV disinfection.
So I just approach it with some caution, because it's not something that we routinely recommend. We do know that it is effective against some organisms, but when it's implemented, there are often implementation challenges. And some of those implementation challenges might be compounding the variation in the data, related to effectiveness. So, I think when you're dealing with something that is an adjunct, that's fine if you want to use that, but you still have to make sure that your bases are covered by the full implementation of those basic processes. And so I think that was the focus of your talk, Elizabeth. And then I think, if we were looking at those no-touch disinfectants, I think it's always just a little, I would approach with caution, because many times those are treated almost as if they're silver bullets, and they are not. So just caution in that area.
Thank you, Janet. I think we have maybe, yeah, it looks like she was saying it's an adjunct after discharge cleaning.
There's a really tough question that I just want to raise. The person asked, do you think that facilities are able to follow recommended cleaning protocols on a daily basis? Many facilities are in staffing crisis and experiencing such high rates of turnover that I think it's difficult to have adequate time and resources to adhere to recommended protocols. And I just want to, let you know that we are aware and we hear it a lot, and we know that you're just really working so hard, and that it's just been such a difficult time for facilities. So anything you can do to build teams to really emphasize how critically important these measures are. Staffing issues are tough. They're tough and they're not easily fixed. But we appreciate all the effort that you all put into, getting your facilities in a state of cleanliness that is safe for everyone. But I didn't want to dismiss that question. There's no easy answer to that. And we just, want you to know how much we appreciate the work that you're doing.
Yeah, thanks, Janet. Appreciate you addressing that. I thoroughly agree. I think we just have maybe a couple more questions. And Janet, I think I might actually turn this one over to you. That we were dinged in a mock survey for not following manufacturer's instructions for use or cleaning and disinfecting medical equipment. If the instructions for use state to use water and soap, and during the pandemic, we chose to use a product that killed SARS-CoV-2, what do you recommend?
So not sure who conducted that survey. It looks like it was a mock survey. Soap and water, that's basically a detergent that would remove organic debris, but is not intended to kill organisms. Usually with the Joint Commission, they want to know that when there's a difference between the manufacturer's recommendations and something that you are doing, that you have really thought that through and used good reasoning and evidence-based information to kind of guide that decision. So if I had to choose between soap and water and something that would kill SARS-CoV-2 on a piece of shared medical equipment, I would definitely choose the disinfectant. And then I would want to know that it was compatible with whatever surface that was. But usually they're looking for how you arrived at the decision to do what you were doing. Certainly using something that is, effective against organisms is better than using soap and water, which doesn't have any kill claims.
I think we just have one comment from Rehab from Virginia, and she is making a good point that some equipment can't be cleaned with some of the products against Candida auris. So making sure again that you're using the appropriate products for the surfaces that you're cleaning. Janet, do you have any other thoughts or?
Yes, on that one, I think you made a really good point, Elizabeth, about really looking at what surfaces are likely to become contaminated. So on an ultrasound machine, you have the probe, which is going to have a lot of contamination. You have the cord, then you have the screen, which it should not ever be touched really. And then the console itself. So you may need to use different disinfectants for different areas of the same machine. But we certainly don't want you to trash an ultrasound machine trying to clean it with something that's not intended to be cleaned for. But the area where the gel sets, people are going to be touching that all the time, and the gel itself can become contaminated. So making sure that you're using those disinfectants appropriately on the high touch areas of that equipment would be important.
Perfect. Well, I think we are 5 minutes over, but again, really want to thank everyone for joining. And it's, again, check out that website, the Virginia MDRO webinar website for the recordings and the slides. And we'll see y'all next month. Thanks, everyone.